Hello everyone, welcome back to the series of lectures in Pulmonology. So today we'll be learning about hypersensitivity pneumonitis. Okay, so let's begin. So what is hypersensitivity pneumonitis? So hypersensitivity pneumonitis is also known as extrinsic allergic alveolitis. Okay. So hypersensitivity pneumonitis is also known as extrinsic allergic alveolitis. As the name suggests, what is the pathophysiology behind HSP? So this is a pulmonary disease that occurs due to inhalational exposure to a variety of antigens, resulting in inflammatory response in the alveoli and small airways. Okay, so what does this mean? So you have different types of inhalational exposures. You can have organic dust exposures, you can have bird dropping exposures, you can have agricultural exposures. So all of these can kind of elicit a hypersensitivity response in certain individuals, resulting in damage to the alveoli and small airways, and this is what we call as the HSP. Okay, clear? Now, let us look at the different type of antigens and what type of organisms can result in HSP. So this group of disorders have different types of antigens, different types of species, and they all have different names. So this list is very difficult to remember, and hence to cut the monotony and help you remember this list easily, I have come up with some picture mnemonics. So for those who are comfortable with reading the table, please do go back to the HSP's chapter in Harrison's and go through the table. For those who find it difficult in remembering names, you can use these mnemonics to remember the names. So, the first mnemonic that I want you to remember is this. So, this man is basically a farmer carrying a bag of potatoes and mushrooms. So you remember a farmer carrying a bag of potatoes and mushrooms. Okay. So what is this? So these are basically 4 disorders which we group together. That is your farmer's lung, bagasosis, potato riddler's lung, and mushroom worker's lung. So all of these are named disorders which are all part of hypersensitivity pneumonitis, and all of these occur due to inhalation of what? Inhalation of a particular organism which is associated with this is your thermophilic actinomycetes. Okay. So farmer's lung is caused due to inhalational exposure to a lot of organic dust, and the organism is thermophilic actinomycetes. Similarly, bagasosis basically occurs due to inhalation of sugarcane dust which is again contaminated with this thermophilic actinomycetes. Then you have potato riddler's lung and mushroom worker's lung in similar fashion. So the easiest way to remember what all is caused by thermophilic actinomycetes, you remember farmer carrying a bag with potatoes and mushrooms. Second, this is somewhat a strange mnemonic, but it is quite easy to remember. So what is this looking like? This is looking like a mill, correct? This is looking like a mill. But what is this mill made up of? You can see these green colored fruit. What green colored fruit does it remind you of? It reminds you of your green colored custard apple, which is nothing but sitafal. Okay. So what are these 2 words going to remind you of? So you remember miller's lung. Miller's lung is due to Pseudophilus species. Miller's lung is due to Pseudophilus species. So mill made up of sitafal, miller's lung due to Pseudophilus species. Then third, this is a wine bottle, correct? This is a wine bottle. Okay. So which HSP are you going to remember with this wine bottle mnemonic? Remember wine worker's lung due to botrytis species. Wine worker's lung due to botrytis species, and it occurs due to exposure to grapes. Exposure to grape farming, wine worker's lung botrytis species. Okay, fine. Then fourth, what is this weird organism, right? So this is basically an organism having multiple pseudopods. Okay, so multiple legs. So you remember pseudopod, which sounds like, or which helps you remember, Pseudomonas. Okay, and what is this organism doing? It is basically operating some machine. Yeah, so this is basically operating a machine. So you remember machine operator's lung. Machine operator's lung. Okay, so machine operator's lung is Pseudomonas. So you remember a pseudopod, Pseudomonas operating a machine. Machine operator's lung is Pseudomonas. Okay, fine. Now, another very strange image. So, who is this? This is a person who is clad in his clothes. And where is he sitting? He is sitting in a hot tub. He is enjoying a hot shower, hot tub, clad in his clothes. Another weird thing that you will notice here is he is seeing his MacBook. Okay, so MacBook, you have the symbol of the Apple company, right? So Apple on the laptop or the iPad, this is a MacBook. Okay, so why have I made this mnemonic? So you remember hot tub lung. Hot tub lung is by Cladosporium species and Mycobacterium avium complex or MAC. Mycobacterium avium complex or MAC. Okay, so you remember hot tub, clad, man clad in his clothes is Cladosporium, and your MacBook is going to help you remember Mycobacterium avium complex, right? And the last mnemonic which I would like you to remember, wood is an alternate material. So wood worker's lung. Wood worker's lung is by Alternaria species. Okay, so these are some mnemonics which I come up with, hoping that it will help you remember the entire list a little better. There are a lot more organisms, but these are the most important organisms that you have to remember. Also remember, certain other antigens that you have to remember includes bird fancier's lung. So bird fancier's lung happens due to what? It happens due to inhalation of bird droppings. Okay, so any of these antigens in any of these type of exposures can create a hypersensitivity response, resulting in damage to the alveoli. So that is the reason why you should remember these fancy names and the fancy antigens and organisms. Okay, so we are clear about this, right? Okay, so let us move forward. So what is the pathogenesis of hypersensitivity pneumonitis? So first is the antigen exposure. What are the different types of antigens we have just seen? So these antigens basically result in precipitation of IgG antibodies. So every antigen is basically going to result in an antibody response, and this results in precipitation of IgG subtype of antibodies, which are called as precipitants. Okay, now this antigen antibody reaction basically results in a dysregulated T helper 1 and T helper 17 responses. So there is overactivation of your T helper 1 and T helper 17 responses, and hence there is excessive inflammation of the airways. So this finally results in uncontrolled excessive inflammation of the airways and bronchioles. Okay, there are some genes which are associated with the genetic predisposition. Remember TAP1 gene and MHC2 mutations. Clear? Okay. Now, let us look at the clinical features. So, acute hypersensitivity pneumonitis usually occurs 4 to 8 hours after the inhalation of the inciting antigen. So, someone who is not at all a farmer, okay, so he goes to a sugarcane factory and he ends up ends up inhaling this sugarcane dust, and there is Thermophilus actinomyces on that. Then what happens? So within 4 to 8 hours of the inciting antigen, you can have an acute hypersensitivity pneumonitis, which is characterized by fever, chills, malaise and dyspnea, and this will be very similar to a pneumonia. So this will be very similar to a pneumonia. So you might misdiagnose the patient as a community acquired or a viral pneumonia. Okay, so it presents with fever, chills, malaise and dyspnea, or it may also present with an acute respiratory distress syndrome kind of picture. Okay, so it becomes very important that you ask the exposure history clearly so that you don't misdiagnose the patient and you treat them differently. You can also have subacute forms of HSP. So in the subacute forms of HSP, so whenever there is an inhalation of the inciting antigen, they have symptoms but it is not so severe, then it becomes calm for some time and then it comes back again. So you can have intermittent episodes in your subacute types of HSP. In your chronic hypersensitivity pneumonitis, it presents with cough, weight loss, clubbing, and over the course of time it may progress to ILD or interstitial lung disease, and then the evaluation and management is going to be different. Okay, so this is about the 3 forms in which your hypersensitivity pneumonitis can present. So acute, subacute and chronic forms. So chronic forms can mimic interstitial lung diseases with cough, weight loss and clubbing. So how do we diagnose your HSP? Fine. So in your acute HSP, you will have fleeting infiltrates. You will have fleeting infiltrates in your acute forms of hypersensitivity pneumonitis. So the diagnosis of acute forms is quite difficult to make because they largely mimic your community acquired infections. So in your subacute forms, this is what you have to remember as a spotter. So whenever there is a subacute form of HSP, you can find that there are areas of this white appearance, these areas which are white, which are called as ground glassing, plus areas of normal lung. There can be areas of normal lung, plus there are areas where there is hyperinflation, which is much darker when compared to the normal lung because of air trapping. So you can have ground glass opacities with normal lung with air trapping, and this is what we call as the triple density sign. This is what we call as the triple density sign or the head cheese appearance. So this is what we call as the triple density sign or the head cheese appearance, which is a characteristic feature of this subacute forms of hypersensitivity pneumonitis. So ground glassing, presence of centrilobal nodules per air trapping, which is called as your head cheese appearance in the CT image of hypersensitivity pneumonitis. Okay. Now in chronic forms of HSP, if you do a pulmonary function testing, you can have an obstructive pattern which can progress to a restrictive pattern in the later stages. You can have a restrictive pattern as well. Now other tests which are used to diagnose your hypersensitivity pneumonitis includes serum precipitants, which will be elevated because of your exaggerated antigen antibody responses. Then bronchoscopy, another very important point when we do a bronchoalveolar lavage. So what do you do in a bronchoalveolar lavage is that you do a bronchoscopy, you visualize the bronchioles and the airways and you take up samples from there. So once you take out the secretions and you see that the BAL CD4 to CD8 ratio is less than 1 and there is a BAL lymphocytosis, very characteristic feature. So if you really have to differentiate your acute HSP from maybe a community acquired infection, then you'll have to see that the BAL CD4 CD8 ratio is less than 1, or your bronchoalveolar lavage, when you do and the samples are taken, there are predominance of lymphocytes, unlike in infections where you have predominant neutrophils and you can have growth of organisms, which is not going to be there in your hypersensitivity pneumonitis. Okay, so always remember BAL CD4 to CD8 ratio less than 1 and BAL lymphocytosis. Very rarely we will have to do a lung biopsy. So if at all you do a lung biopsy, you see the presence of non-caseating granulomas with multinucleate giant cells. Okay, where all do you find non-caseating granulomas? We have just learned you can find it in berylliosis, but in berylliosis, these non-caseating granulomas are loosely arranged. They are loosely arranged. You can also find it in sarcoidosis, and the other condition is your hypersensitivity pneumonitis. Okay, and there are predominant lymphocytic infiltrates. If it is a chronic type of HSP, then you can have evidence of fibrosis as well. This is mainly seen in your chronic forms. Okay, so what are the differential diagnosis of hypersensitivity pneumonitis? Yes, in your chronic forms, it can be similar to your interstitial lung diseases. Then just now we had discussed sarcoidosis, organic toxic dust syndromes like berylliosis. Okay, so these are the differential diagnosis. So how do you manage your hypersensitivity pneumonitis, right? So most of the time it is conservative treatment, but the mainstay management is the use of steroids. So you start it, which is basically prednisolone at 0.5 to 1 mg per kg. Okay, so this you go and give it for around 2 weeks and then you taper and stop. So steroids form the mainstay management for hypersensitivity pneumonitis. Alright, so with this we have come to the end of our discussion on HSP. We will be discussing about pulmonary infiltrates with eosinophilia, or what we call as eosinophilic lung diseases. So let's begin. So we will look at the eosinophilic lung diseases in broad detail and then go into the specific details one by one. So pulmonary infiltrates with eosinophilia can be due to primary pulmonary eosinophilic disorders like acute eosinophilic pneumonia, chronic eosinophilic pneumonia, EGPA, which is a type of vasculitis, eosinophilic granulomatosis with polyangiitis, and hypereosinophilic syndromes. Then there can be pulmonary disorders of known cause which is associated with peripheral eosinophilia. So this includes your asthma, your allergic bronchopulmonary aspergillosis, which is ABPA, or you can have drug or toxin-like reactions, parasitic and helminthic infections, or other non-parasitic infections. So all of these can cause infiltrates in the lung and they can be associated with eosinophilia. Then other lung diseases associated with eosinophilia includes HSP, IPF, pulmonary Langerhans cell histiocytosis. Then neoplasms associated with eosinophilia can also cause pulmonary infiltrates like leukemias, lymphomas, lung cancers, adenocarcinomas. Systemic disorders associated with eosinophilia can also cause lung infiltrates like radiation-associated pneumonitis, RA, sarcoidosis, Sjogren's. All of these can be associated with eosinophilia. So RA, sarcoidosis and Sjogren's. Fine. So this is about the broad classification of eosinophilic lung diseases. So the major takeaway from this slide would be, if you have to know about the different causes, or if a patient presents to you with pulmonary infiltrates and eosinophilia, you have to see whether this is due to a primary pulmonary process or due to a systemic condition or due to drugs or toxins or due to infections or malignancies. Okay, so this is the major takeaway from this table. So what is the pathophysiology of these eosinophilic lung disorders? So the major pathophysiology that has been found is that there is a dysregulation in the interleukin-5 production. So we know that the interleukin-5 is basically involved in the stimulation of eosinophils. So whenever there is a dysregulation or an upregulation of this interleukin-5, there is excessive production of eosinophils due to unknown causes, and these eosinophils then migrate into the lungs. In certain conditions like EGPA is eosinophilic granulomatosis with polyangiitis. EGPA is eosinophilic granulomatosis with polyangiitis. So in this condition, what happens? There is a necrotizing vasculitis. And there is eosinophilia. And here this is an autoimmune disorder which is characterized by antinuclear cytoplasmic antibodies. Okay, so this is an ANCA associated vasculitis, right? So these are the two major pathophysiologies that have been identified in these kind of eosinophilic lung disorders, especially the primary eosinophilic lung disorders. The eosinophilia associated with systemic diseases or other diseases, that is a different game altogether. So first we will look at acute eosinophilic pneumonia. Okay, so let us look at the diagnostic criteria for acute eosinophilic pneumonia. So this is characterized by an acute febrile illness with respiratory manifestations of less than 1 month in duration. Okay, so this is characterized by an acute febrile illness with respiratory manifestations of less than 1 month in duration, and it is characterized by hypoxemic respiratory failures with diffuse pulmonary infiltrates on the chest X-ray. So if you just consider the first 3 criteria, what will you think this is, right? So this is very difficult to differentiate from your community acquired pneumonia. It is very difficult to differentiate from your viral pneumonias. It is very difficult to differentiate from maybe your hypersensitivity pneumonitis, because all of these can present very similar with an ARDS kind of picture, right? ARDS of course has a more rapid progression. It progresses within 1 week, but it can go up to 1 month in this condition. But if you just look at the history, the progression, and X-ray will just show diffuse pulmonary infiltrates, it is quite difficult to just diagnose this as an acute eosinophilic pneumonia with just these 3 symptoms, right? Because it is a great mimicker of a lot of other lung conditions. So what is the highlighting feature of your acute eosinophilic pneumonia? Is a characteristic feature of a bronchoalveolar lavage. We had discussed about BAL in our chapter on hypersensitivity pneumonitis, right? So if you do a bronchoscopy and you take out the material for that and do an analysis under the microscope, it will show eosinophilia more than 25%. So this will show the presence of BAL eosinophilia more than 25%. Okay, and very importantly, this is a diagnosis of exclusion. So there is absence of any parasitic, fungal or any other infection, absence of any drugs known to cause pulmonary eosinophilia. Okay, so this is a diagnosis of exclusion, and there is a quick response to corticosteroids. Very important. There is a quick response to corticosteroids, and there is no relapse after discontinuation. Most of the time this is a monophasic illness and it does not have any relapses after you give them a good dose of steroid. Okay, so this is about the diagnostic criteria for acute eosinophilic pneumonia. So acute eosinophilic pneumonia is an eosinophilic lung disorder which is characterized by a rapid onset of symptoms and progression within 1 month, and hypoxemic respiratory failure, diffuse pulmonary infiltrates, and it is a diagnosis of exclusion. And the most important feature that you have to remember is BAL eosinophilia more than 25%. We had learnt about BAL lymphocytosis, BAL CD4 to CD8 ratio less than 1, that is in HSP. So if you have to differentiate all of these conditions, the final diagnosis would be by a bronchoalveolar lavage. So bronchoalveolar lavage eosinophilia more than 25%. And they have an extremely good response to steroids and they do not have many relapses. Okay, fine. So we have already seen how will you diagnose. You see that the BAL eosinophil count is more than 25%, and since this is an dysregulated inflammatory disorder, you see that the inflammatory markers ESR and CRP will be elevated, and you see the presence of peripheral eosinophilia. Very important point. You will find the presence of peripheral eosinophilia. Usually the absolute eosinophil count is more than 1000. It is more than 1000, right? And you can find the presence of pleural effusions, and if you do a pleural tap, there will be an increased pH and you will find eosinophilic infiltrates within the pleural effusion as well. Okay, fine. So what is the management, right? So you have to do a BAL, and the main or the cornerstone treatment for your acute eosinophilic pneumonia is systemic steroids. So you start at around 1 mg per kg and you do a tapering dose so that the patient shows an phenomenal response to this, and most of the time this disease is non-relapsing of nature. Okay, so that is about your acute eosinophilic pneumonia. Now let us look at chronic eosinophilic pneumonia. So chronic eosinophilic pneumonia is predominantly seen in females, non-smokers at around your 40 to 45 years of age. So it is commonly seen in females, non-smokers at about 40 to 45 years of age. So what is the clinical feature? So this is more of subacute, chronic in onset. So it presents with dyspnea, and it presents with wheezing, presents with episodes of dyspnea and wheezing. and they do not present very acutely like in acute eosinophilic pneumonia. They do not present with hypoxemic respiratory failure. They do not present with hypoxia. They predominantly present with dyspnea in episodes of wheezing. Okay, a characteristic X-ray feature that you have to remember, a particular catchword which is called as your photographic negative of bat wing appearance. So this is called as the photographic negative of bat wing appearance. So what is the meaning of that? So we know that the bat wing appearance, this is called as your bat wing appearance, right? So where do you find this bat wing appearance? We have heard of this in your cardiogenic pulmonary edema, correct? You heard of this in your cardiogenic pulmonary edema. So what is photographic negative, right? So if you see your cardiogenic pulmonary edema, this on an X-ray, it appears like a bat wing appearance from your hilar nodes. It is white in color. So if that area is black in color and the infiltrates are predominantly peripheral, right? So on your X-ray, you find this bat wing which is basically black because your white infiltrates are predominantly peripheral, and that is why it's called as your photographic negative of your bat wing appearance, which is a characteristic X-ray finding which is seen in chronic eosinophilic leukemia. Okay, so this is found in chronic eosinophilic pneumonia. Fine. So what are the highlighting features of your chronic eosinophilic pneumonia? So you might very well, it might be similar to asthma. So how do you differentiate that? In the CBC, it shows peripheral eosinophilia more than 30%. Certain long-standing asthmatics may also show peripheral eosinophilia more than 30%. Then how will you differentiate bronchial asthma from this, or how do you even suspect it, right? So these will be patients who are non-responders, right? So, and when you do a bronchoalveolar lavage, again you see that the eosinophilia is more than 60%. That is an alarming number, right? So here you find that the bronchoalveolar lavage shows more than 60% eosinophils, which is not found in your asthmatics. Okay, so this is your chronic eosinophilic pneumonia. Okay, and what is the treatment? Again, these patients are responsive to steroids. However, the relapses are more common, and hence anti-interleukin 5 inhibitors like mepolizumab are being tried. Okay, so these are the newer drugs which are used in the treatment of chronic eosinophilic pneumonia. They are still being tried for the treatment of chronic eosinophilic pneumonia. Okay. The next group of disorders that we should be aware of is your eosinophilic granulomatosis with polyangiitis, which is EGPA. The older name was called as Churg-Strauss syndrome. So the older name for EGPA is Churg-Strauss syndrome. So you will have to remember certain characteristic clinical features. So this is usually characterized by recurrent episodes of asthma. So most of the time EGPA patients are being treated as asthmatic for long years before the diagnosis of EGPA has been done. The characteristic feature is that this is characterized by other organ damage. So in your respiratory system, it predominantly presents as asthma. Then in your central nervous system, they have a high risk of hemorrhagic more than ischemic strokes. Okay, there is high risk of hemorrhagic more than ischemic strokes, right? In the skin, what do you find? You can find purpura, you can find urticaria, you can find evidence of vasculitis. Why do you find all of this? Mainly because EGPA is an ANCA-associated vasculitis. This is a ANCA-associated vasculitis which predominantly involves the small vessels. Okay, ANCA stands for anti-nuclear cytoplasmic antibodies, which go and deposit in the small vessels, and they result in a necrotizing vasculitis. Which is the highlighting feature of EGPA, which is not found in any other types of pulmonary infiltrates with eosinophilia. Okay, so anytime that you have this kind of a presentation, a long-standing asthmatic with severe peripheral eosinophilia, always look for evidence of vasculitis because EGPA is a great mimicker. Okay, so you can have skin manifestations including purpura, urticaria because of vasculitis, cardiovascular manifestations including NMI can be there because of vasculitis of the coronary vessels, and if this is there, it indicates a worse prognosis. So if there is evidence of cardiovascular dysfunction, it indicates worse or poorer prognosis. Apart from MI, they can also have myocarditis. They can also have myocarditis, and myocarditis is going to present as heart failure. Myocarditis is going to present as heart failure. Also, you can have gastrointestinal manifestations, which includes eosinophilic gastroenteritis, eosinophilic gastroenteritis and eosinophilic esophagitis. So, if there is eosinophilic esophagitis, how is the patient going to present? The patient is going to present with dysphagia or odynophagia. And what is the characteristic endoscopic appearance? That is your feline esophagus. Feline esophagus is a characteristic endoscopic appearance of eosinophilic esophagitis, and you will find trachealization of the esophagus. So, esophagus actually is similar to your tracheal rings, right? So, feline esophagus is a characteristic feature of eosinophilic esophagitis. Okay. Apart from that, they can have GI vasculitis. The GI vessels can have vasculitis and they present with massive upper or lower GI bleed. They can have colitis, they can have ischemic bowel. Okay. So, all of this is because of vasculitis and eosinophilic infiltration into the GI tract. They can also have renal manifestations in the form of membranoproliferative glomerulonephritis. Okay. Fine. So, you can see that EGPA can affect any part of the body, right? So, they predominantly present as asthma or long-standing allergic sinusitis features can also be present, right? There can be risk of hemorrhagic strokes, and in the peripheral nervous system, a very important point, they can cause mononeuritis multiplex. They can cause mononeuritis multiplex, where you have multiple nerves which are getting affected. So, one particular nerve may be the median nerve, and then you can have ulnar nerve involvement, you can have sciatic nerve involvement. So, you can have varying degrees of weakness because of mononeuritis multiplex because of your vasculitis. Then you can have purpura, cardiovascular involvement and GI involvement and renal involvement. Okay. So, this is about the various clinical manifestations which can be seen in EGPA. Of course, in the lung you will have infiltrates with eosinophilia. So, a very important catch point that you have to remember here is that EGPA can be paradoxically precipitated by the drugs which are used in the treatment of bronchial asthma. So, whenever you use leukotriene modifiers like montelukast, in fact, you can worsen this EGPA and you can diagnose EGPA at that time as well. Okay, fine. So, let us look at the laboratory features which aid in the diagnosis of EGPA. So, up to 30 to 40% of the individuals will show P-ANCA positivity or MPO ANCA positivity. Okay, and they show the presence of peripheral eosinophilia, again more than thousands. ESR-CRP will be elevated. When it comes to the radiography, there can be evidence of bilateral patchy infiltrates, bilateral ground glass opacities, bronchial wall thickening, subpleural consolidations, pericardial pleural effusions, and sometimes, very rarely, you can find evidence of lymphadenopathy as well. Okay. So, the most characteristic feature, underlying feature that you have to show is the presence of vasculitis. So, if there are skin lesions, so you do a biopsy, or if you find GI lesions, you do a biopsy and you find evidence of vasculitis, then this is EGPA and not any acute or chronic eosinophilic pneumonias. So, treatment again involves steroids, cyclophosphamide, other immunomodulatory therapies like azathioprine or rituximab. Okay, so this is about the management of EGPA. Now, the next syndromes that we should be aware of is your hypereosinophilic syndromes. So, what are hypereosinophilic syndromes? Hypereosinophilic syndromes is characterized by peripheral eosinophilia more than 1500 with organ damage in the absence of other secondary causes of eosinophilia, right? So they can have end organ damage very similar to EGPA. They can have CNS involvement, GI involvement, they can have lung involvement, kidney involvement because of eosinophilic infiltration. Okay, so hypereosinophilic syndromes are characterized by eosinophilia more than 1500 with organ damage in the absence of other causes. So what are the causes of this hypereosinophilic syndromes? It can be due to myeloproliferative disorders because of genetic mutations in the platelet-derived growth factor receptor beta, JAK2 mutations or FGF mutations. Then we have chronic eosinophilic leukemias and you have the lymphocytic type of hypereosinophilic syndromes. So the three types you have to remember is the myeloproliferative type, the lymphocytic type and the chronic eosinophilic leukemia. In the lymphocytic type, you will see that there is evidence of increased IgE levels. Okay, fine. So hypereosinophilic syndromes will present very much similar to that of your Churg-Strauss. Okay, so what are the certain characteristic features which will help you differentiate between the two? So as far as the laboratory features are concerned, there will be of course peripheral eosinophilia more than 1500, but you remember that there will be increased tryptase, there can be splenomegaly, B12 levels may be increased and bone marrow examination will show more than 80% hypercellularity because this is most often due to a myeloproliferative neoplasm. So there will be bone marrow infiltrates more than 80% cellularity. Okay. 20 to 50% of the patients can also develop restrictive cardiomyopathy and endomyocardial fibrosis. Apart from that, they can have GI, kidney, skin involvement, very similar to EGPA. Okay, fine. So the characteristic features that help in differentiating hypereosinophilic syndromes from your EGPA is that they will not have ANCA positivity, they will not have any evidence of vasculitis, and they are never responsive to steroids, right? They are never responsive to steroids. Okay. So these are the most important features with help in differentiating from EGPA. Okay. No ANCA, no response to steroids and no evidence of vasculitis. So this is about your hypereosinophilic syndromes. Now we will move on to another very important disorder which is your allergic bronchopulmonary aspergillosis, which is ABPA. Okay. So what is ABPA? ABPA is basically a disorder which occurs due to allergic sensitization to Aspergillus antigen. So we know that many of the chronic asthmatics are on steroid therapy or on inhalational steroid therapy. So this will predispose to your colonization by fungi like Aspergillus, right? Now if this Aspergillus colonization is there in the airway, the Aspergillus antigens can result or can trigger an allergic response, and this is what results in your allergic bronchopulmonary aspergillosis. Now ABPA is different from invasive aspergillosis. It is different from invasive aspergillosis. So ABPA is different from invasive aspergillosis because invasive aspergillosis causes vascular invasion and it causes destruction of the lungs, destruction of the bones. Okay, it causes vascular invasion, destruction of the lungs, destruction of the bones. Here in ABPA, you only have an allergic response to the fungal antigens and there is only colonization, unlike your invasive aspergillosis where there is invasion and destruction. Alright, fine. So what are the clinical features? Again, what are we discussing? We are discussing pulmonary infiltrates with eosinophilia. So ABPA can also be associated with pulmonary infiltrates with eosinophilia. Okay, and you find a characteristic bronchiectasis over the course of time because there is excessive amount of secretions which can block the airways and result in clogging of the airways and bronchiectasis, and the type of bronchiectasis that you find here is the central bronchiectasis. So you find central bronchiectasis in your ABPA. The diagnostic criteria for ABPA is that, very importantly, when will you suspect it? You will suspect it in any patient with uncontrolled long-standing asthma. Any patient with uncontrolled, long-standing asthma. And the diagnostic criteria for ABPA is your ESHAM criteria. The name is ESHAM criteria. So what are the characteristic points under this ESHAM criteria? So any patient with asthma or cystic fibrosis, there are 3 mandatory criteria. The mandatory criteria for the diagnosis of ABPA includes IgE specific to Aspergillus fumigatus, where the IgE to Aspergillus fumigatus is elevated to more than 0.35 kilunits per liter, a positive skin test is positive, and total serum IgE levels are also more than 1000. So, Aspergillus specific IgE greater than 0.35 or a skin test positivity and a total serum IgE is also more than 1000. Other criteria for at least 2 of which has to be present is Aspergillus specific IgG, means that there has been a previous exposure. So, IgE is a mandatory criteria, IgG is a other criteria. Okay. Then radiological changes for ABPA is present. What are the radiological changes? Presence of central and proximal cylindrical bronchiectasis. Okay. Alterations predominantly involving the upper lobe, right? Cystic fibrosis, ABPA, all of these cause upper lobe bronchiectasis. Presence of nodules, atelectasis, air trapping. Then the third criteria is eosinophil counts more than 500, right? So if any 2 of these 3 are present, and the mandatory criteria are present, then you diagnose the patient as ABPA. So this is about your ESHAM criteria for the diagnosis of ABPA. Remember, your mandatory criteria are Aspergillus specific IgE elevated or skin prick test positive and total IgE more than 1000, and the other criteria 2 out of 3 is radiological or IgG levels or eosinophilia. Okay, Aspergillus specific IgG levels or eosinophilia. Fine. Okay. Now let us look at the radiological features of ABPA. So you can see here that there are predominantly upper lobe infiltrates, and can you see that this is looking like a finger in glove appearance. This is looking like a finger in glove appearance which is seen in your ABPA. Then in your CT, you find that this is mucus impaction within the lung, and the attenuation, they are actually much more whiter or solid as compared to the surrounding areas, and this is what we call as the high attenuation mucus. High attenuation mucus or HAM, which is a characteristic radiological finding of ABPA. Clear? So this is about your different imaging findings of ABPA. What is the treatment of ABPA? Treatment basically involves steroids. You give it over a long time along with antifungals like itraconazole. So you give itraconazole for more than 4 months. So it helps in reducing the colonization and your ABPA response. Clear? Okay. Fine. So next let us move on to the infectious causes for your eosinophilia and pulmonary infiltrates. So among the infectious causes, you will have to remember that a lot of parasites can also be associated with pulmonary manifestations and eosinophilia. So you would have learned this in your basic microbiology. What is this? This is Loeffler's syndrome. So the first point that you have to remember is Loeffler's syndrome, and this basically occurs due to migration of parasites within the lungs. So this is caused by Ascaris, hookworms and schistosomiasis. Then certain parasites can cause direct penetration into the lungs, and this is what we call as visceral lava migrans. This is visceral lava migrans. Then there can be an increased immunologic response which results in eosinophilia and pulmonary infiltrates, which is seen in filariasis. Then cystic parasites, which is including echinococcus and cysticercosis, and other disorders associated with eosinophilia includes TB, coccidiomycosis and basidiomycosis. Okay, so this is about the huge list of infections which can cause eosinophilia. So with this, we have come to the end of our chapter on pulmonary infiltrates with eosinophilia or eosinophilic lung diseases. Thank you.